Okay. All right, yep, that's fine. We did that last week, 2 weeks ago. Is everyone happy with that? Yes? Okay. Now, ladies and gentlemen, we're going to have a look at, we've looked at the heart and lungs. We're going to now look at the downstream effect of what we've done. And then we're going to look at a trauma system. And then we're going to look at a real patient. Tonight, we're only going to get as far as a couple of other organs, all right? Because trauma affects everything. Everyone happy with that? Let's go, Athol.
Is that still sharing?
No.
Oh, shit. I'm sorry about that. This computer of mine's playing up tonight. Share screen.
That's looking good. All right, let's go.
Okay.
Terrific. All right, renal, next slide. Okay, so kidneys are basically simple in their response to trauma. We can damage them, as we'll come to, but by and large, there's not a lot you need to do. Best guide to resuscitation. It's simple, it's splanchnic circulation, and the first thing that's going to go off is a concentrating ability, which means your urine output will diminish whilst your kidneys are trying as hard as they can until they fail to suck up every bit of sodium they can with that water. So urine output becomes your friend. However, there are a couple of caveats to this game. To absorb sodium, you've got to give up something with a positive charge, and that's potassium and magnesium. Now, if you remember, ladies and gentlemen, we need those two electrolytes to maintain your heart's filling. Remember, your ventricle does not fill very well in atrial fibrillation, does it? So, as part of the response to preserving sodium, which is what you're going to do, your body's going to give up potassium and magnesium, which means you as junior staff need to have that front and center in your mind to maintain your cardiac output. Next slide. So, urine output, a couple of things. The human body is standardized to 70 kilos. 35 mils an hour, therefore, is half a mil per kilo per hour. If you're fat like me, it's still 35 mils an hour. Okay, if you're an athlete like Athol, it's still 35 mils an hour, all right? It's really important because someone's 200 kilos does not mean we expect 100 mils an hour of urine. It's lean body mass. So 35 to 40 mils an hour is perfectly adequate unless we're driving it for a reason. Now, we may do that in certain circumstances. One would be burns, another one would be rhabdomyolysis, etc., where we're trying to maintain a higher urine output. But we're doing that for a purpose. We're not doing that as a routine. Okay. So burns patients come to mind in this slide because urine output is the only parameter that has ever been used in burns patients to show an adequate resuscitation. There is no other measurement we've ever been able to devise, be it invasive, non-invasive, or anything else, which tells us adequate resuscitation. So consequently, it is an exceedingly good form and can be done anywhere. Even the average surgeon can master putting a catheter in and a urine output, and it gives you an hour-to-hour guide of your resuscitation status. Now, if we add to that the fact that we can do serial venous gases, as we've talked about, in most places with point-of-care testing, then your base excess will also reflect the adequacy of your resuscitation. So you see how you can start to build a feedback loop in without knowing. You don't have to know CVPs, you don't have to have invasive monitoring, you don't have to have anything. This will do. So if the skin is warm, the capillary refill is less than 2 seconds, your urine output is adequate, and your base excess is not getting worse, and you're decreasing the amount of volume you're giving, happy days, you have done well. So that is the basis upon which we resuscitate, and that's why kidneys are important. Next slide. This is the reason. Go above that one. Renal blood flow is lost first and early. So it is an exceedingly, no, go down one, Athel. Result, urine output, next slide. No, you're going up instead of down. Go down one, next slide. Next slide. You're going up.
Going the wrong way.
You're going the wrong way. Stop there.
Yep.
Okay, so for you guys, there is nothing you can do to preserve renal function except give an adequate cardiac output. It's very simple. The rest of it is beyond the ambit of this talk, and indeed beyond the ambit of most, if not all, ward patients. So kidneys have been good. They're an early warning system for you. They will go off early. They do go off and you give too much fluid, we have to deal with it. If they do go off and you give a shot of Lasix, nobody is going to castigate you. I know there are all sorts of myths out there that Lasix is bad, yada, yada. The answer is yes, it is. If you've got renal failure, it ain't going to make them better. But one dose is not going to hurt you one way or the other. So rest a little easy when you become residents. Next slide. Hepatic, next slide. No, you've gone up instead of down.
Yeah,
down one. Yeah, I want hepatic. Next slide.
Yeah.
No, that's renal. I want hepatic. Next slide down after that.
It's hepatic on my screen.
It says it. I want the next slide down after that one, mate. Keep going forward.
Okay. Hepatic function.
Yep. Okay, so again, what do we need out of livers? So, since I can see a few faces there, Daniela, what is a liver function test?
Liver function test would test the AST, ALT.
No, that's rubbish. Sorry, sweetie.
Right.
That's exactly what I wanted you to say. That's a liver enzyme that will tell me where the problem is. What does the liver do? So come back now and tell me what the liver does, Daniela. And
sorry.
Yep.
It creates our coagulation factors.
One,
it also helps with bile production and first pass metabolism.
Yes, two, that's terrific. And it makes albumin.
Makes albumin, yeah.
So the reason I want you all to be cognizant of that is one of the great furphies you will come across in your career is people getting head up about liver function tests. It's a crock of rubbish unless you know what the function is. And the function, as you quite rightly said, Daniela, is coagulation, is bilirubin, is glucose control to an extent because you've got glycogen, and albumin. The liver enzyme profile will tell me where the problem is. Now, this is important because a liver enzymosis is almost ubiquitous in trauma because you get blood loads everywhere, you get a bit of bilirubin, but without an enzyme change, it's because of the bilirubin. If, however, I have that enzyme rise with a rise in bilirubin, I have to think I've got a hepatic injury. Do you see the difference? Now, the next one is everybody who is sick is vitamin K deficient. Just cut to the chase, 3 times a week vitamin K if you're sick, just give it. Okay, so how would we assess vitamin K deficiency, Makey? You can ring a friend if you like. Carolyn is ready and poised. I can see it there. She's like a coiled spring.
Yes, I'll ring a friend.
Go on, Carolyn, tell me, how would you assess?
Vitamin K.
Yeah.
Clotting measure.
Terrific. Which ones?
Prothrombin time.
Terrific. Right. 2, 7, 9, and 10. It's the extrinsic pathway, TV channels. Terrific. Okay. The intrinsic pathway, which is an APTT, includes factors 8. Okay, as well. So you can do it on a prothrombin time. That's the easiest way to think of vitamin K dependent cofactors. Now, what is vitamin K? What does it actually do? Does anyone know? And Daniela, you're as far as my screen goes, and there are other people there. So let me see. If I press a little arrow here, do I get other people? Oh, look, I've got a whole thing. I've got a Hannah 14-7. So I'll have one of those. Hannah, 14.7.
So
Yeah.
I think what it does is basically activates the coagulation factor. So basically,
Terrific. Well done, you. Well done. So it's a really important concept. Vitamin K does not help the liver make it. It activates it. And that's a really important concept. So well done. So most people who are sick are vitamin K deficient, okay? And that vitamin K deficiency usually persists somewhat longer than the other organ things. So if you're sick 3 times a week, a vitamin K is almost a ubiquitous thing. So we've looked there and I've said loss of function is coagulopathy. Initially, it will be 2, 7, 9 and 10. If your liver failure is bad enough, you'll knock the rest off as well, but 2, 7, 9 and 10 are the most common. We can have a whole other talk on coagulation issues on another day if you want. That's fun, but we don't need it for this. Lactate is there for 2 reasons. One is that you make it, and until you prove otherwise for your patients, it is because they're hypoxic at end organ level. Now, there are other reasons with liver impairment that you might get a high lactate. For your purposes, that doesn't matter, because if you think about it, they're sick, aren't they? So if your liver is already parlous with cirrhosis, your lactate may be up. But if you think about it in the context of trauma, it's just an early marker of an organ that's already failing, isn't it? The only other organ that metabolites lactate is kidneys, and we already said they're going to go first or second, aren't they? So lactate becomes quite a sensitive marker because the 2 organs that deal with it to get rid of it are jettisoned pretty early via our splanchnic circulation. So lactate in trauma goes well. Bilirubin, because why might your bilirubin be raised in trauma? Let me see, I've got this thing here. I've got an Enki who's got a black screen. So Enki, you can tell me, why might bilirubin go up in trauma?
Probably from problems with red blood cells.
Terrific. Why is that? Well done. Well done. Why is that, mate? You're quite right. Why?
Red blood cells being broken down and not being replaced fast enough.
Well, just broken down. So in trauma, you get a hematoma, and a hematoma, we're going to break it down. The unconjugated bilirubin is going to go to the liver. If there's too much of it, you go yellow. Absolutely. So one of the reasons we need to look at the bilirubin is to see where our problem is, isn't it? If it is unconjugated, it means it's before the liver. If it is conjugated, it's either due to a cellular inability. The commonest one you would see worldwide would be hepatitis, but drugs alone can do it, etc. Or an obstruction or damage to the biliary tract, and that's cholestatic. And our liver enzymosis pattern will tell us which that is. In trauma, in general, you get a hepatocellular pattern because it's pretty hard to block the biliary system. So in general, you'll get an unconjugated hyperbilirubinemia, which reflects nothing more than the hematoma volume, and then a conjugated hyperbilirubinemia, which reflects the fact that we've overwhelmed the liver if we have enough blood that we're trying to metabolize. Make sense? So we don't often see a cholestatic picture. If we do, we have to go looking for trauma in and around that biliary tree because we've got an obstruction, haven't we? Okay. Blood glucose, you're not going to see acutely, but certainly over 24, 48 hours, you will in somebody who's already malnourished because glycogen is broken down to glucose, isn't it? And it's stored in the liver, isn't it? So after about 24 to 48 hours, we may exhaust that supply. However, in our population, diabetes is endemic, and I don't know about Samoa, but I would guess is becoming so in Samoa. So the implication of your patients arriving with trauma and on diabetic medication will mean the hypoglycemia may become seen earlier because you have an unopposed action of the drugs without the diet and the glucose load that they need. So hypoglycemia we are seeing somewhat earlier in trauma simply because of the demographic of our patients now. So it's something we didn't used to have to put there, we do now. Next slide. As I said, almost all severely ill patients are vitamin K deficient. That's trauma, anything else. Most common thing is a raised prothrombin time. Now, liver disease alone, but there's coexistent renal disease, hence we tend to make the lactate and the ketones worse because of liver and kidney interaction. Suffice to say for you, whilst there are various causes for lactate rises and ketone rises, it's easy. It is always hypoperfusion until you prove otherwise. And the time you didn't prove otherwise, you will invariably find it will be someone who was either starving, drunk, or is on one of the anti-diabetic drugs which make the liver and kidneys make ketones and or lactate. So in essence, it's an early marker of those people on those drugs because the circulation wasn't good enough and the drugs are doing their job. So it's still hypoperfusion, albeit as an early warning system because of the drugs they're on. So for you, lactate is always hypoperfusion until you prove otherwise, and invariably it still is. It just happens to be not quite as much hypoperfusion because we will find other triggers to have done it. Is that clear to everyone, or do I need to put it another way? So those of you who have looked at diabetic patients, the two big ones you need to think about is the metformin. Metformin defaults to turn pyruvate into lactate, and then that lactate is then either hidden in fat or is metabolized in the kidneys. Consequently, if I give you a shovel load of metformin as an overdose and you are not shocked, you will weird out, you will not get a lactate rise. You might get hypoglycemic, but your lactate won't go up because your liver and kidneys are well perfused. If on the other hand, you have any hypoperfusion of your splenic circulation, you will get a vast lactate rise because the drug's doing its job. The drug that gets to the liver is telling the liver to convert pyruvate to lactate, but the poor old kidneys aren't getting enough blood to get rid of it. So it goes up. Now, if we then think of the new SGLT2 inhibitors we see for diabetes, they do the same thing with ketones. What they do is hide glucose by basically telling the kidneys not to reabsorb it. Well, gee whiz, if I don't have enough splenic circulation, they're going, oh, make ketones, make ketones, make ketones. Oops, I don't have enough glucose and I've now got big problems and I get a ketosis. So they get a normal glycemic ketosis. In fact, what we're seeing here is inadequate splenic circulation in diabetics who are on these drugs and their early marking or early warning system of hypoperfusion or starvation. So the principle still works for you. If the ketones are up, but more importantly, their lactate's up, there is hypoperfusion. You may just see it earlier in this target group of patients. Okay, and we're seeing that more and more as we starve people for surgery. We're now seeing people turning up with ketones in their urine after a night's starvation in diabetics because they're on SGLT2 inhibitors. We never saw it before, we are now. All right, next. And heavens knows, planned surgery is good trauma. The blood gas you do venous is going to tell you contemporaneous glucose, is going to tell you base excess, is going to tell you electrolytes, will tell you lactate, and you can get now point of care ketones by dipstick out of their urine. From your point of view, the best protection you've got is urine output and your point of care testing. Next slide. Gut. Next slide. Okay, this is a funny little thing to show you all gut does. From my point of view, and your point of view for the rest of your life, gut membrane is a dialysis machine. You have feces and food on one side, you have blood on the other side, and you need to put nutrients across that membrane. Hence, that mucosa is there to stop bacteria going one way and fluid and needed electrolytes going the other. That is all gut does. But it needs two things. One is it needs circulation to keep it alive. And two, it actually needs food. It gets about 10% of its own nutrient from its lumen. So early feeding is paramount for these patients to prevent them getting ulcers because they erode their mucosa. So in the ward, early feeding. Now, when people go, oh my God, if all we need is we need 10 mils an hour. If someone is so powerless they can't take 2 teaspoonfuls of feed down a nasogastric tube, then I'll be thinking they're a lot sicker than, you know, when the surgeon has a conniption about, oh my God, don't feed them early. We're talking 2 teaspoonfuls of stuff. It's not a lot. So if their little dodgy anastomosis is that bad, come on, if the trauma's that bad, we've really got to wonder whether we shouldn't have been looking earlier. Now, if we give them PPI inhibitors, and we can, we will increase their risk of aspiration pneumonia many-fold. So you're better off feeding them early, and there is good evidence for feeding them early. In burns patients, for example, they're fed from the time they arrive, they're fed before theatre, they're fed through theatre, and they come back from theatre fed. We don't fast patients out of ICU to theatre anymore. They go fed and they come back fed. So whilst you would fast them for their initial surgery, there's no reason you shouldn't be feeding early, and if possible, feeding by gut. And this is not just a third world issue. If I feed anyone by gut, I improve their nutrition, I improve their immune status, it's cheap, and they're going to do all the work for me to fix up their electrolytes, because that's the way it's supposed to be done. I don't know, I'm a lazy creature. If I can stick something down a nasogastric tube and your patient will do all the work for me, it sounds a lot easier to me. Now, where this will become vital for you in the gut is when we turn to head injuries. We know head injuries lose sodium. It's part of having cerebral salt wasting. The best protection we have is a high protein diet. We pound protein into them. We absorb the protein. The kidney then, in the urea cycle, will absorb sodium. Let's see, I can either think about how much hypertonic saline I'm going to give and have to do a lot of maths twice a day, or I can give them a high protein diet and let them do it themselves in their kidneys. Which one do you think I do in intensive care? So if it's good enough, and that's why we feed early and why we feed a high protein diet, because it just gets rid of a whole lot of problems, that can be something easily done in a ward, which means for trauma, when you're the ward residents, early feeding, early gut feeding and high protein is the best you're going to come up with. Next slide. So again, since splanchnic circulation is lost early, gut and ileus is an early marker, not just that we have damage in the abdomen, but we have inadequate resuscitation of the patient. It's the same splanchnic vascular tree that we have for kidneys, liver, and gut. So again, if somebody is eating, and I had this in a patient today, and I'll give you a scenario today, which isn't quite trauma, but it will illustrate it. Somebody said, oh, we have a patient with a fever. They've got a pneumonia, multilobar pneumonia with flu A. We think they might have a cholecystitis. Now, their albumin is 18, so they've done an ultrasound and they've got a thick gallbladder wall. Well, the fact is everyone with an albumin of 18 has got a thick gallbladder wall. My response was, are they tolerating feeds? And the answer was yes. Food went in, no ileus, and they were passing bowel motions. This person cannot possibly have an acalculitic cholecystitis. There is no one, you think about it, who is, if someone's sick with a cholecystitis, do they eat, tolerate food, and defecate normally? No. This is the same as you've got. So you can use the gut as a marker. If you've got bowel sounds, they're tolerating feeds. The most sensitive end organ circulation you've got, because you're going to jettison it early, is working. Well, gee, we can add that now to our renal output, can't we, as a fairly good non-invasive marker of adequacy of resuscitation simply by using physiology. That's what you're going to jettison first. If it's working, well, probably everything else upstream is doing all right. So that's the way we can start to use these patterns to help you manage patients. Next up, next slide. Which patients warrant a laparotomy? So, next slide. Indications for blunt trauma are pretty much that, abnormal with suspected injury. Now, we will come to that with a caveat because we may well do tests before this. But as a thought process, remember we said, where can you be bleeding? Blood on the floor and 4 more. So if I can't see it, both femurs look all right, their pelvis doesn't spring and their chest x-ray is okay, there's not a lot of other places to hide a lot of blood, is there? So we have to think about that. The alternative is free gas, which is why we do a chest x-ray, diaphragmatic rupture, which is why we do a chest x-ray and look for either the gastric bubble or a nasogastric tube there. Peritonitis, which you are not going to see early unless you have feces. Blood is relatively benign, as is bile, as is urine, by the way. And lastly, the various invasive tests we can do, and we'll come to that in a little more detail in a while, but these are all available. I'll put all 3 in. In the Western world, we would do a fast scan. If that shows not much, they can get that. All that tells me is they're good enough to go to CT. In the third world, you may still do a DPL, which is astonishingly sensitive and will tell you whether or not there is abnormalities there, but it won't tell you where they are. Next slide. Penetrating trauma is easy. If it goes anything through the fascia, they get a laparotomy, is the thought process. The rest of them, as you can see. Early operation generally is what happens if it goes. If you can put your finger in and it goes through the fascia, they might as well head to theatre because that's where this is going to go for a look-see. Next slide. CNS. We're going to spend a bit of time here because this is the one with the most morbidity, ladies and gentlemen. Next slide. Okay, this is how I think of brains, and we see about 3,000 head injuries a year through my ICU. It is a 1,500 ml box with very sharp edges, and it's got a spongy thing in the middle, of which 20% is brain, 20%, 30% is CSF, and 50% is blood, half, and that 50% is 30% venous and 20% arterial. The only space you can buy in this 1,500 ml box is to chuck 75 mils of CSF down into their spinal canal and 75 mils of venous blood out through their jugular foramen. And after that, the pressure must go up. There is no other choice. So out of 1,500 ml box, we have exactly 150 mils to play with before the pressure goes up. Not very much. So we need to be very careful up front with brains and how we're going to deal with them. Next slide. Put another way for that. No, go the slide above that, Athel. You went 1 slide too far, I think. That's it. Put another way, you can think of it, if you think in pictures, this way. You've got 75 mils of CSF, and you've got 75 mils of venous blood. That's it in the bottom part. And after that, the pressure must go up. So we need to bear that in mind as we go through this because we'll look at the various injuries. Next slide. These are the normal pressures inside your skull. 20 is magic end organ, everything number in the body. It is intraocular pressure above which you get glaucoma. It is intracranial pressure above which we're going to drain the box, make the box bigger, or whatever. It is left ventricular end diastolic pressure above which you will get pulmonary edema. It is intra-abdominal pressure above which your kidneys and bowel will stop working because of a compartment syndrome. It is compartment syndrome in limbs. And basically it is transcapillary pressure. So 20 is the number you think about when you're talking about end organ anything. Now, why is this important? The next slide. This is what we've been talking about so far, 75 mils until you decompensate, then you're going to push the brain out through a hole, and that's called herniation. But, like the ad, there is going to be more to these steak knives. Next. Your brain normally, remember that normal shock table, you can burn 40% of your blood volume and your brain will auto-regulate because it will increase the oxygen extraction from the blood it gets. That's how it survives in shock without a head injury. That's what it does. It uses a lot of energy, but what it does is it auto-regulates and yanks more out of the blood we're delivering. Happy days, terrific. But remember, it's got a poor reserve because it's already extracting a shed load of energy, but it can do more, and it's not got capacity to swell. Next slide. The brain's got its highest uptake in the frontal lobe, which is why we do voice and that. However, with head injuries, you lose the ability to auto-regulate. Gone for at least 48 hours, possibly longer, depending on the type of injury, and certainly in diffuse ones, probably longer. So at the very time we need the maximum ability to auto-regulate across our blood-brain barrier, it leaks like a wretched sieve, and it becomes flow dependent and pressure dependent. It loses its ability to auto-regulate. This, for you as young doctors, is crucial because any and all discussion that you may ever read about minimum volume resuscitation, hypotense resuscitation, and we'll dwell on this more when we come to our index case, stops at the very minute there is a head injury. It must, because we run all of those resuscitations against a coma score. And in a head injury, we have lost our guiding parameter. So when you deal with trauma that excludes heads, and the commonest one is a stabbing or a gunshot, we will quite often run blood pressures of 60, 65. They'll jettison their kidneys, what the heck, we can dialyse them. But if their brain is working, the rest will turn on. It's a uni-system problem with penetrating trauma. If, however, we have a coexistent head injury, as you are going to see with blunt trauma, because it tends to be a field of fire effect, hypotense resuscitation is not used because we do not have that end organ to measure it against. Is that very clear to everybody? Yes? Okay. All right. So just hold on. Someone's... Wait a minute. It's all right. I'm not on call, but someone just wanted someone else. That's fine. My phone went off. Okay. So it's a very, very important concept for you all. I'm sorry, I'm trying to do call as well because I was covering someone until 7:30. So it's just that they've just said that they're there. That's sorry. It's a very important concept for you guys. So who has been exposed to, say, a ruptured abdominal aortic aneurysm? Has anyone seen anything like that or know of that? We will take those to theatre, barely awake, but there's no point in giving blood product or volume until we put a clamp over the aorta. But their head is intact. Completely different from a head injury as part of multi-trauma. All right? So that's the two ways to think about it. A stabbing is nothing more than a ruptured aneurysm done another way. Next slide. So this is what I mean in this complicated slide, but you need to take only a couple of messages. You will see with traumatic brain injury, we lose the green autoregulation capacity. Flow and pressure are now coupled. Without an adequate MAP, i.e. an adequate diastolic pressure for our left ventricle, we have no flow. With no flow, we have no brain. To show you how important this is, I've given you some very sobering figures below. One episode of a recorded saturation below 90%, 20% worse outcome for a head injury. Coma score for coma score. One episode of hypotension, defined in the field as a systolic of more than 90, 20% worse outcome. Combine them, 200% worse outcome. And that reflects the fact that you need both a pressure and enough oxygen, because we are now coupled. We have lost the ability to auto-regulate these patients. So in head injuries, we're going to have slightly different end markers, because there's little point in having someone with terrific kidneys and everything else if they're now in a nursing home. Next slide. So the aim is for a cerebral perfusion pressure of 55 to 65. You're going, my God. Hannah is going, how will I achieve that? Well, we're going to assume, aren't we, the intracranial pressure is 20, aren't we? Because it's upper end normal. So even an aging intensivist like me getting enough fingers and toes out goes 20 plus 55. I know a map of 75 to 85 is good. And you can see that's exactly what we do. We do a map of 80 to 90, and that's where that fictitious number comes from. Until we can put a drain in or a monitor in to measure it, we assume in a head injury the ICP is 20 at upper limit normal. We add 55 to 65 to that, and that is the map we target. Now, generally, by day 4 to 7, we may alter that. That is beyond the scope of this talk. We will do it if, in fact, we have a bad, very angry brain, which we're just making good go after bad, and 20% of them will do. That is beyond the scope for this talk. ICP minus MAP equals CPP. Other way around, Hannah. MAP minus ICP. Otherwise, you're going to get a negative number. All right, but yes, you're quite right. MAP minus ICP equals CPP. Well done. Now, Comodera's next rule. If the patient is doing it themselves and their MAP's over 90, I have to have a compelling reason to drop that, because they're doing it for a reason, aren't they? So if they're already doing it themselves, I'm not going to go, oh, duh. I think I'll drop it because a map of 60 is what we normally go for. Hello? It's looking real bright. They're doing it for a reason. So I have to have a very good reason to drop that map. And that is really a CT and a lot of thought and a lot of looking at their history. All righty? Now, how do we decrease the fluid burden? Well, surgeons are good. They put holes in things. That's very good. We can drain the hematoma. And that's been around for 2,000 years. The Romans recorded doing that. The Egyptians did trephinus for it. It's been around a long time. The second thing we can do is drain the CSF. So you make 20 mils an hour of CSF. Remember I said magic end organ number's 20? So we can stick a drain into the ventricles and drain 20 mils an hour of CSF. That buys us space. Thirdly, we can just take the whole bone off. So if we go to the next one. Oops, go back one. And lastly, we can decrease its oxygen need, can't we? So we intubate, ventilate them, and put them at normothermia. Please note it's normo, not hypothermia. Certainly your ICP will go down if we cool you, but you don't clot. So it's a recipe for a bad outcome. So we go for normothermia, not hypothermia, unless there's a compelling reason to do so. Now, it is a last tier. Absolutely, we will do it. But we don't kid ourselves we're going to get a good outcome here. All right, and it's done in consultation with the neurosurgeons that there is no more options. We're not going back in. We will give it a go. That's different from this part of the talk, okay? You want normothermia because the best protection your patient's going to have in the field, certainly in Samoa with the head injury, is they can clot. So normothermia is good. Okay, next. Now, how do we classify head injuries? Look, you can do it by skull fractures and this, but to be honest, we do it by CT and things like that. So I'm giving you the way you will hear it done, and then we'll talk about how we really classify them. So skull fractures, yes or no? Those of you who cannot get CT scans, plain X-rays are notoriously bad at finding skull fractures, okay? You'll miss up to 20%. So without a CT, a plain X-ray is not really, it doesn't rule it out, it's a rule in. Base of skull, you're really after leak or nerve palsy, but it's really what you see. So why does anyone get raccoon eyes, for example? Can you help me there? I've run out. Wait a minute, I'm going to flick. I've already picked on the front group. Lawrence, haven't heard much from you, mate. So why do people get raccoon eyes or black eyes with a CSF leak? What is it? Or the base of skull fracture, sorry?
I have no idea, but I'm just having a go. Perhaps.
Terrific. Well done.
No perfusion to the area?
Not quite. So if we think about it, if this fracture bled on the inside, we'd call it an extradural, wouldn't we? Why don't we just let the blood leak out? And it goes out and we call it raccoon eyes or otorrhea. All it is the fluid's gotten out instead of going into the cavity. That's all a base of skull fracture means. It's a fancy term, but that's all it means, guys. So we don't get too set. Yep, battle sign, yeah, look, it's true. More commonly, you're going to see blood plus CSF coming out of their ear. And the trick is not Dextra sticks, as every nurse will say, oh, last time I looked, blood's got sugar in it. The trick is look at their pillow. There's 3 halos, then it's going to be blood and CSF, and if it's their nose, snot, because there's different sugar in each one. So you look for the halos. Dipstick won't work because if there's any blood there, both CSF and blood have sugar in it, so it's not going to help you if it's out of a nose and you've got a discharge, is it? So you look for halos on blotting paper or halos on the pillow. Next slide. Okay, this is now getting to the real thing. Focal injuries and diffuse injuries. Focal injuries are a bone bruise which pushes on the brain. That is an extradural. The brain itself is unaffected by the extradural. It may have a brain injury with the force, but the extradural is just pushing it away. I'll have some CTs for you to look at in a minute to show this. A subdural is in the space between the dura mater, and for those of you who are very upmarket people, the dura mater is ossobuco or Lamshanks, the sinew on the bone. Think of it as periosteum. That, in effect, is what dura mater is. There is no extradural space anywhere. It is fictitious. It's stuck to the bone. So if we bleed into there, you will peel the periosteum off and it will have a discrete edge. A subdural lies in a real space, and it's between the dura mater and the arachna or pia mater that covers the brain and is intensely stuck to it. In that space runs little veins. Hence you get a real space, a real collection, and it looks like a crescent on CT, but in fact, you don't ever see the front or back of it because there is no front or back, because it's a real space that goes all the way down half the skull and round and down the sinuses. Intracerebral and subarachnoid blood will be under the lining of the brain or in the brain. And I'll have pictures of these in a tick for you. Diffuse injury, concussion, is a clinical injury, meaning there is a normal CT with a loss of consciousness. As we now know, that is probably a very simplistic view of what is a brain injury. We just probably don't have, or we certainly don't have the machines yet to look at it acutely. Contusions and ischemia. So let's go to the next slide. Oh, there we are. So this is an extradural hemorrhage. Classically, either there, that's a bit far posterior, that'll be out of a sinus. But you see how it's got it's a sharp edge. It is a bone bruise pushing the brain away. By and large, it will do well. It tends to be a low-speed injury, treated early, does well, because it's a bone bruise on a brain. You have relatively little brain damage. The reason we know that, looking at this one, is if you look at the midline there, see there is no midline shift. So the brain underneath is still plastic enough to have been allowed to squash a bit, push out a bit of CSF, because you can see on the other side there's a little black ventricle. We've just effaced or squashed the ventricle on the side of the bleed of the white there, see that? So we pushed out a bit of CSF, but this is an otherwise brain. We drain that, that will come up. So these tend to be a low-speed injury, and unless there is an underlying brain injury as well, should do well. Next slide. On the other hand, a subdural, as you can see here, is a much worse injury. And there are two reasons for this. One is if it's a young person, we must have shaken the brain enough to tear the veins. So as opposed to you've had a bit of a hit on the skull, we've got a bone bruise that's pushing the brain. Now we've had to tear the brain enough to tear the little veins in that dural space. That's a young person, so it tends to be a fairly high-speed injury. If you look at it, it's white down the sides. We'll do another talk later on CTs of heads, which will look at this. You see it's white, but you see you can't really see an edge, and that's because there isn't one. If you put a sucker in that, you'll suck all that out and there'll be blood there, but there's no edge because it goes all the way down the midline. But have a look at the midline there. See how that's pushed across? Everyone see that? See how much it's pushed across more than that little bit of subdural. So I've got to have brain injury as well, haven't I? There's got to be something else swelling, isn't it? So just draining that subdural, we've still got an underlying brain injury here. We have to. So when we look at the brain injury, it's not just the degree of subdural, and 5 millimeters generally is what we want to take out. It's also, is the midline shift more than what we're seeing with the blood collection? And if it is, we've got diffuse brain injury as well. And that's how we start to, you'll see for the same coma score, a neurosurgeon go, this one's going to do badly, this one isn't. On seemingly the same radiological diagnosis, the reason is we don't just look at the subdural, we look at here, well, that's a subdural with about 5 millimeters. That midline's got at least 8 or 9 millimeters. We've got a heap of problems here. We must have underlying brain damage, contusion, injury, because something's making that swell more than just that. So it starts to tell us a story. Next slide. And this is the classic motorcycle helmet one. So what we have here is frontal lobe contusion, but it's just an intracerebral hemorrhage. These are notoriously horrible with their morbidity, because the very thing that makes this socially acceptable on a Saturday night has just been lost with this injury, hasn't it? So when we look at prison populations, we have a disproportionate number who have had frontal lobe injuries in various forms of trauma. And that is the bit that gives you your social wherewithal. Most people do not need an operation. That doesn't mean most people are going to do well. Okay? Their morbidity can be quite large. Next slide. This one I put up to caution you a little bit. The one on the, as you see it looking at it, the one that says normal CT, have a look at how nice the ventricles are. Have a look at, you can see grey matter as we'll do with the thing. You can see little lines and things. The one on the right is diffuse injury, and that will look almost normal at time 0. A diffuse brain injury is something that takes a lot of force, and basically think of it as chucking a plate of jelly out of your countertop and then pick it up and give it back to mum and dad, and that's what that brain looks like. And that's diffuse axonal injury. The reason you need to be careful is the original scan will look almost normal because it is an intracerebral shearing type injury that will evolve over 4 to 7 days and not be at its worst for up to 2 weeks. This is important when you say the following or you hear someone say the following to mum or dad. The scan looks normal. What would you interpret as parents if you were told that? So if you're unconscious, your options are 1, on the Gold Coast, drugs and alcohol. 2, you've got a diffuse injury. That's quite right, Vinay. 2, you've got a diffuse injury. 3, you've had a fit. If it's drugs or the fit, you wake up. If it's diffuse injury, 1/3 of you will die if your coma score is under 8. 1/3 of you will be top of the class in the nursing home. 1/3 of you will get home and won't be what you were before. And that scan looks relatively normal. So be careful with your terminology. It's just a caution for you all that terminology matters, because as Vinay has quite rightly pointed out, if you were a parent and you heard scan looks normal, of course it is. The original normal scan fills us with dread because we're not going to know for 48 hours until we repeat the scan which one of this is, or the next day we'll lighten them up if they look okay and see what we get. But we don't know, and we have to be very careful with families to say we simply don't know. The scan at 48 will begin to give us a look. The scan at 4 to 7 days will give us a better look at where the circus is going. All right, next slide. This is the way you will then also look clinically. So we've looked anatomically at how we can classify them. Clinically is by coma score, mild, moderate and severe. Pretty much 13, 14, 15, 9 to 13, and lastly severe. So which type of trauma can lead to diffuse blunt injury, Marky? And it's blunt and it's high speed. And this is one of the reasons, by the way, when you see people convicted of child scan, it's one of the reasons that they didn't fall out of bed. They're the sort of injuries you get with a shaken child. You don't get a bone bruise. So when they go, oh, they fell out of bed, no. Falling out of bed might give you an extradural. Falling out of bed may give you a subdural. Shaken baby gives you that. And that's high speed, stopping quickly, and the brain basically just shattering against the bone. So that's shaken baby syndrome. So that's the sort of force that you need. Next slide. Now, this is where we play the game. And what we're going to do is play an odds game here, ladies and gentlemen, of who do you scan. Now, in my hospital, it's easy. Any doubt, you just get a scan. I've got some rules for you coming up, and we've got them in the bits at the back on who to scan and why and who to pan scan. So there are rules for this, and there are guidelines. Okay, so there's the Canadian guidelines, there's consensus guidelines. They're in the rest of the talk, and just download it as to what you do. Coma score of 13 or 15, we do our usual trauma series. Your CT is indicated. To be honest, in a tertiary hospital that runs a scanner 24/7, if you're anything other than 15, bang. I never do alcohol or drug screens, okay? Can I now put my hand up? I never do them, ever. Useless. Someone's coma score is low, their coma score is low with a head injury until I prove otherwise. Never, ever, 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 ever due to drug and alcohol. Because somebody will say it's that, they'll sleep it off. So I just don't do them. A coma score of 13 is a coma score of 13 is a head injury. That's it. I do not do alcohol or drug tests for the patient. We do them forensically for the police, that is for the courts, and that is for a legal issue. I do not do them ever for treatment of the patient. Never. Because it confounds or clouds what should be a binary decision. Okay? My cutoff is coma score 14 and below gets a scan. And the reason for that is the miss rate at 13 for me is a little high, but I have access to a tertiary scanner. When I was in the country, 13 I'd watch, and we would batch them until the morning, and we'd run them all through in the morning. And that's a safe approach as well, because you can't call people in for every head injury you're going to see in a country hospital. Okay, next slide. 9 to 12 are easy. They all get a scan. Okay, the miss is too high. 20% is going to be what you're going to find. You're going to find 20% of these patients are going to have something on a scan, and 20% of those, it's going to get worse. So cut to the chase and just scan them. Okay, 9 to 12, the price is way too high. The miss rate for 13 to 15 is about 3%, of which you're going to operate on only about a tenth of those. So you can make a case for batching them and watching them. 9 to 12, that number's too high for me. No one's going to argue with scanning a 9 to 12. Nobody. Next. Severe is easy. Airway, breathing, circulation, pan scan. We'll come to why we pan scan these when we go through all the various guidelines. But in essence, unless you have a normal coma score, the bottom line is that if you've got a brain injury on a CT, you've got a 10% chance of having a spine, and if you've got one spine, you've got a 10% chance somewhere else. If they're going to go to the scanner, you just cook them top to bottom. And the very things that you were relying on for your abdominal examination, which is a patient that could tell you something, is unreliable. So now you can see why you're going to be looking at imaging the abdomen at the same time. So you get chest as well. So the pan scan rules will come to us how they evolve and why we do them and when we do them. But head injury 3 to 8, in fact, anything under 12 just gets pan scan because the patient is unreliable, and all of the criteria will come to, and we've got all the checklists for you. Basically, that's the cutoff. Next slide. Focused examination is pretty simple. A coma score, pupils and lateralizing signs. Okay, why a coma score? Coma score is historical. It was formulated in 1974 when people were trying to figure out who we could scan when we only had minimal CT scans. The three things picked are pretty simple though. Voice is the most sensitive. It's frontal lobe. It'll go off first. Eyes were there to tell them in the days before CT which side to drill. Your pupil will blow 95% of the time on the affected side. And motor is a 50-50 bet acutely because it depends on whether you push the brain above or below where you're going to cross over with your fibres. But in ICU, it gives us an idea of who is rehabilitable. So that's why those three were picked, for no other reason. Next slide. What do you do to optimise? Here you go, ladies and gentlemen. Here's the recipe. You want SATs above 92%. we've lost auto-regulation, and we know one episode of hypoxia is bad. So normally in our patients, we'll tolerate 88% to 92. We run everyone at that. The bets are off for these patients. You want 92. Okay, minimum 92, because you've got an element of time should this things go wrong. Daniela, is the devil talking to you? I can see lights flashing. You got spooked. Are you all right? No, you look spooked just now. Okay.
I'm good.
We're going to assume an ICP of 20, aren't we? Now, you can't get a map at the scene, so there are the systolic pressures that we like and the Brain Trauma Foundation support at the scene. You can see they're fairly high for what we would normally use for trauma, but the reason is we don't have our end organ here that we're trying to protect. That's going to work for us. Next slide. You want normoglycemia. Please, normo, not hyper, not hypo, normoglycemia. That means in the ideal world, we would run these people 5 to 7. I run them from 6 to 8 in my ICU. And the reason for that, we run them at that, we run them tight. You can run them anything. We know anything under 10 is probably okay. Over 10 is marginal, over 12 is bad. 6 to 8 for us, where we have nurses on site and around the clock, means we can run them tight. In a ward setting, you certainly want them to be under 10 and you want them to be over 5. So you need to adjust your insulin, if they're diabetic, for that, to run them like that. You want euvolemia. Please note that's euvolemia. It makes no sense at all to give somebody a shed load of fluid. Which other compartment syndrome anywhere would we shove a lot of fluid into a closed space? And yet we see it all the time. You've got a thing called a brain in a box that last time I looked, that bone doesn't expand much. Oh, and we're going to give feeds plus 3 litres of fluid a day and wonder why they go off in the ward. Oh my God. This is the one area that strict fluid balance matters, ladies and gentlemen. It is a compartment syndrome. It is no different from a leg. You just can't see it, can you? You've got a squashy thing in a box. Making it swell with fluid you don't need is not a real good idea. So we want euvolemia, please, which means a urine output of 35 mils is terrific. We don't need 70. No need to overachieve here, ladies and gentlemen. 35 is good. They would have an IDC, and that's why 35 is right, Marky. And we use that. Okay, we can use it rigorously. Well done. Next. Next, yep. Hypertonic. Okay, you will, when you become interns, see us use this stuff in ICU all the time. Yes, we do, and we do it for a reason. It is not for you to use in the ward. So my recipe is different from what I'm putting here for you for a ward setting. Hypertonic fluids for you buys you time to get to theatre. And in fact, all they do is suck water out of the extracellular space, and eventually, hopefully, you wee it out. Whether you use mannitol or hypertonic saline is irrelevant for you. Now, what I do is I run everybody on hypertonic saline, but I use it as my maintenance, and I use 3 times normal saline, divide the volume I would normally use by 3, so I'm giving salt, not a lot of fluid, and making that hypertonic milieu suck fluid out of the extravascular space. Now that's fine, I do this for a living. In your case, you want isotonic fluid, not 4 1/5, not 3 1/3, not anything else with damn glucose in it as maintenance. Got it? Because what we want to do is give them their carbohydrate by feed with a shed load of protein in it. Because that protein, when it's absorbed, the kidneys are going to do your sodium work for you. Anticonvulsants are not controversial, but are used if we have an extraaxial collection, are used if we have a skull fracture, are and should be stopped when they leave an ICU because they're often forgotten about in the ward. If they're not, it's usually for a good reason, i.e. they've had a fit in the unit. They do not, and early anticonvulsants do not prevent long-term seizures. They do, however, help us in ICU because early on, with an irritable brain, they don't fit early. We stop them before they leave because they knock your IQ down. So if they come to the ward with anticonvulsants, one of your jobs as a resident will be to ask why and should they. And that's a very sensible thing to ask because there has to be a good reason to use them. Everyone gets sedated with a head injury who's on a ventilator. Paralytics we use, but only with enough sedation. And the reason we do that is we do not want you coughing or straining, which will push up your intracranial pressure. So tier 1 for us is intubation, ventilation, and blood pressure control to the appropriate MAP. ICP we manage. We push your sodium up routinely to about 150 to 155. Next tier would be paralyze you. Next tier would be to cool you down to low isothermia, and then a barbiturate coma. They're the 4 tiers we would use for a head injury. For your purposes, a MAP, which is a systolic pressure as I've given you, euvolemia, normal glucose, and then the hypertonic solutions only as buying measures to theatre is fine. Next slide. Surgical scalp wounds, you can bleed to death from a scalp wound, particularly your patients on their antiplatelet stuff. Remember, if you pinch it together or just roll it back on itself, you can stop it very quickly. So flick it over and it will stop. All right, so scalp wounds are there. Direct pressure usually works. Personally, I find residents very good for that because you can always change one after they get tired. So they're very good. But joking aside, tow truck operators can just provide pressure and they'll do it very well. Next slide. Penetrating trauma is basically pretty simple for heads, airway, breathing, circulation, CT scan, and do not take out the penetrating thing, please. We need to know what it might have gone through. If it's going to bleed, we'd rather it not be bleeding until we're ready. So don't take it out. Okay, next. Cranial mass lesions. So here we go, and this is what everyone's going to worry about. Yes, immediate neurosurgical consultation, but even in Queensland, that may mean 24 hours away. So we've got to have something we're going to buy time with. The bottom line is we need to control that mass lesion. So there are 2 ways to do it. Surgeons are good at draining things. The rest of the thing is we do not want to make it worse with what we do. So we can buy space by giving minimum amount of extraneous fluid and rubbish and controlling their brain metabolism to stop additional swelling. We can't stop the bleeding without a surgeon. What we can do is stop the rest of the brain being damaged with secondary damage. That's our job. Surgery drains things. Next slide. Options. Next slide, hopefully. Here, for example, is our extradural. We drain it, put a hole in it, drain it, brain come up, happy days, stop. Next slide. So these are the concepts. Here we put an EVD in, we buy space. So here you can see someone has blood, it's subarachnoid blood, and all we've done is put a big plastic drain in. You just drill a hole in the skull and just put it into the ventricles. It's actually not hard. Some ICUs do them. They're usually done in theatre, but I've done them in ICU, and technically it's not that hard to do. And it's basically like doing a lumbar puncture and drilling a hole. And you can then get 20 mils an hour of CSF out. It buys some space. Next slide. Here, we can't do much. You see the blood up there behind the right eye. So this is a subdural and intracerebral bleed there. We're going to have to optimise the oxygen delivery and decrease the extraneous oxygen need. That's not drainable. So this stays in ICU and that's what we do. Next slide. Here is the diffuse axonal injury I talked about. This will be about day 3. We're going to optimise the oxygen here. See how our brain is starting to get all those little white specks in it, in a fairly featureless brain? That's all little blood collections as we've torn the neurons and axons. So that you won't see that initially, that will evolve over days. Next slide. Hematology. All right, we're up to, what number are we up to slide here? Keep going.
Keep going.
All right, what slide are we up to, Athel?
It doesn't show me the slide number when I've got it on this.
I'm just looking at the time. That's fine. We've got time. Keep going. All right, hematology, next slide. Can we ask a question? Oh, all right, you can, Hannah. You're not going to die wondering. Yep, ask a question. Go for your life.
Sorry, I actually had a couple of quick questions, if that's okay.
Yeah, of course, darling.
Oh, beautiful. So one of the question is, in regards, because you commented on epidural, which is the extradural hematomas.
That's right, unless you're American, where they call them epidurals, yes.
Yep, so with that one...
Extradural and epidural.
Yeah, I thought from where I read that they are a bit more dangerous than subdural, mainly based on the fact that it's an arterial bleed and you get the lucid interval.
The answer is yes and no. So please, you need to be precise as you're moving to become a doctor. The answer is yes, they will kill you quicker, but no, in that they're operable and done early, they have a fantastically good outcome.
Because there's no midline shift, etc.
No, there's no brain injury. It's a bone bruise pushing on a brain. So if the bleed continues because it's arterial, the brain will be pushed and you will die. If, however, you operate early on them, the underlying brain damage is minimal, if any.
Okay.
So they do very well, yes.
And in terms of the subdural hematoma, you commented on the in a younger population.
Okay. Yeah.
What's the difference between the elderly people?
So you raise a good point, and I should have been a little more precise. What happens with age to your brain?
It shrinks obviously as you atrophies
so,
as you
a low speed injury in an older person will tear those veins, won't it? Because you've got a large axial load.
Yeah.
Now, it's venous bleeding, isn't it? We rely, when we operate on these, because you never find that the bleeder, you actually rely on the brain swelling up a little bit to tamponade the venous bleeding. Doesn't happen in the elderly. So in the elderly, it's a marker of their frailty. It's a marker of the same as a neck of femur. The fact is, unless you can stop them falling over, they keep getting these. And that's why they do so badly in the elderly. It's a low speed injury in a frail person with an atrophic brain. So they do badly because it's a marker of their frailty. The younger folk, provided, and I take your point about the extradural, but an extradural, as I said, is a bone bruise. The younger folk, it's a higher speed injury than the extradural. So it's going to have an underlying brain injury that the extradural didn't have. But it's a higher speed injury because there was less tearing effect on the vein because the veins aren't stretched because there's space there normally. Does that help you?
Yeah, that does. Thank you. I appreciate it.
Yeah, so you'll see when you're a junior resident that some old people will come in for their chronic subdurals, and when we do the CT lecture series, I'll show you, we call them Black Forest cakes because they're black, white and grey, and that's really how many subdurals they've had and how long they've been there. So they're white for 2 weeks, they become grey as you absorb the blood, and then they become black when it becomes water. So you see some of these old people have got multiple layers, which means they fall over a lot. No matter what we do there, if we can't stop them falling over, it's really a palliative procedure in many respects and reflects their frailty.
Thank you.
Okie doke, does that help?
Absolutely. Thank you.
Brain injuries, to my mind, are the most challenging part of trauma, because you can turn out a perfect being with everything else, but if that brain doesn't work, it is all for nothing. So more and more we focus on the brain, and this is one of the things trauma teams have vastly improved, is outcomes for brain injuries, because the rest of it's irrelevant. And it's really important. Okay, next, hematology, next slide. Okay, I put this in here to show you why we don't cool trauma. So head injuries, if I make you, who asked me that question before? Who just asked me that question a minute ago? Who asked me the subdural question?
Me?
Right, well, I don't like you, so I'll make you cold. Your ICP will go down. Okay, it will, because it decreases your cerebral metabolic rate, your ICP goes down, but you don't clot. So have a look at that table to show you what the effect of trauma and clotting is. So you have a tissue injury, you are procoagulant, but at the same time as you consume product and you become cold under 35 degrees, you don't clot at all. Is there any other organ we said didn't work when you're cold? Hearts. So the hypothermia, whilst it sounds great for outcomes, we found it didn't work for out-of-hospital cardiac arrests. It seemed great, didn't work because their brains weren't doing well. Doesn't work for trauma because you don't clot either. So one of the problems we have with trauma is at the very time you are hypercoagulable, should you continue to bleed, you will stop being coagulable at all. And even in Samoa, I reckon if you get blood out of the fridge, it's probably not 37 degrees. What do you reckon? So you give old, cold, red stuff, which is pretty crap at giving up oxygen, and the clotting products don't work. You can see this is a testament to nothing, can't you? So I put that slide there so you can begin to see why early stopping of bleeding becomes vital. And as we'll see when we get to limbs and pelvises, the use now of the various tourniquet or splintage devices to decrease potential bleeding spaces is vital as well. Next slide. The optimal hemoglobin is 7, as I said. Okay, now 7 to 10's there because 7 we know, 7 to 8's probably the right number, but no one's going to criticise you for running at 10. If, however, someone's bleeding, it's probably not a good idea to get it to 5. So, you know, if someone's bleeding, we've got massive transfusion protocols, and we'll come to those when we get to them, in all hospitals for exactly this. Platelets, you need 100 minimum to clot. Okay, in various hematology patients, it's less than that. Rule of thumb, 100. Okay, if you want them to clot, but you're going to put a hole in them, you need 100. A bag of platelets is 42,000 platelets. Okay, that's what a big bag of platelets is. So basically one bag's 42,000. 2 bags will give you enough in most people. Coagulation, we've already talked about, the 2, 7, 9 and 10. However, you will consume fibrinogen as well, because you will start breaking down the clots you've made as well. So we often have to think in these patients when they're bleeding acutely, it's not good enough to just give vitamin K. That's a chronic thing. We need to give fibrinogen, cryoprecipitate, FFP, whatever you've got at hand. And lastly, 7.25 and 35, or you don't clot. Now, the caveat is below that. Your coags will not tell you that because the lab warm them up to 37. Okay, so you're going to have an oozing patient. It is seemingly going to have normal coags. One of the reasons is the lab heat it up to normothermia for their machines. Your patient's not normothermic. So it's an important thought process for you. All right, next slide. All hospitals have one of these. Wherever you're going to work is going to have a variation of these, and there are myriads. They are all basically a one-to-one-to-one protocol. It's a bag of blood to a unit of platelets, and that's a 6,000 bag unit, so the big bag's just 7 bags, and 1 unit of FFP, 111. The reason you don't just give red stuff is there's nothing in red stuff but crap red cells. There is no clotting product. It's long gone. Okay, this stuff's got shelf life for 30 days for your red stuff. Clotting products are long gone. They're gone in 2 days. So you need clotting product as well, and you need some platelets to make it stick. So by the time you're reaching for your second bag of blood, most hospitals will have a trigger for a massive transfusion protocol to be activated. And that's why you need the product as well. Every hospital will be different because you'll go on what you do. My hospital doesn't do that at all, but because we do hearts, we run everything just through the heart protocol because that's what we do all the time. But it is a massive transfusion protocol done another way. But every hospital will have the same. And in country regions, you will have a one-to-one-to-one. You may not have FFP anymore. You may have powdered fibrinogen simply because it has a indefinite shelf life. And it's just set, forget, and bang it in. The other thing that will be there for you all will be what? Crash trial. Okay, let's keep going then. Keep going. You'll have tranexamic acid, and you'll be given a gram and then a gram over 8 hours. Set and forget. The trial was called the CRASH 2 trial, which may come up if you're doing an AMC exam. It was done in sub-Saharan Africa. It has some flaws in that it was largely blunt trauma and it was people who got to hospital. But an all-comers survival was good. The advantage is there is almost no downside to the damn stuff. It's as cheap as hen's teeth. So you may as well just get ahead and give it. And the dose is easy. It's a gram over 10 minutes, a gram over 8 hours. And that is in all of the protocols for transfusions. Next slide. In the ward setting, you're going to now have to think about the next bit, which is anticoagulation, because all of your patients are tailor-made to clot. You're going to put them in bed. So you'll need to think about DVT prophylaxis and when you start it. Now, irrespective of what your patient has, you can do the peripheral things almost from day 0, and that's stockings and or sequential devices. The systemic anticoagulation, being prophylaxis, depends on where they're bleeding and is it easily compressible. So brains in our hospital wait 48 hours. Some hospitals would push that to 5 days. The consensus is probably initially was okay day 1, but since they're hard to stop if they're bleeding, we go 48 hours, some to 5 days. But you will have to consider it, and it is the commonest thing that's missed in the ward because it didn't come from ICU with Clexane or heparin, and it's forgotten. Vitamin K, as I said, is a basic food group for your sick patients, and calcium, of course, because it's factor 4. So you want an ionised calcium of more than 1. Next slide. Massive transfusion, as I said, there it is there. 4 units of red cells in less than 4 hours. Pretty much if you're reaching for the second bag, you've got to have a good reason not to think about activating it. Because by the time you're reaching for the second bag acutely, what do you think the chances are by the time you get all of an infrastructure up and running that you're not going to be at 4 bags? You don't want to be playing catch up. So we get ahead of the game. That's why it's actual or anticipated. Okay? And you can see pretty much they're the ones we said. Blood on the floor or 4 more. Thoracic, pelvic, long bone or belly. Next slide. And there it is. That's the national one, but pretty much that's it. They're all variations of that. Now, nobody is going to particularly care whether or not you've done coags at this stage. They're nice, but if you haven't done them, no one's going to care. Okay, we just bang this stuff in. So the coags are there, but they're nice. Okay? And notice, aim for temperature more than 35, pH more than 7.2. Can I point out you cannot possibly get either of those, nor a base excess of less than -6, unless this person is heading to theatre. The only way you can stop this occurring is with a knife and a suture, because nothing you give them is going to stop that. So whilst that's aimed for, it is sometimes not possible to get. And the job is not get there, because there is no resurrection from there. A lactate of 4 is nothing more than a base excess. Calcium I've given you. Platelets 50, we go for 100, and the rest. Okay, next. Additional agents, as I said there, tranexamic acid. There's the CRASH 2 trial. It is almost no downside. Nobody is going to quibble if you give a gram of that. It's always a gram and a gram over 8 hours. Okay, you can work it out, but it's always that dose. It's pretty easy and it's cheap. Next slide. The result, it's a difficult balance. So for a closed head injury and your anticoagulation, we have to think. So your common patient you're going to see will be a closed head injury plus a fractured tib fib. We know the tib fib's got a huge potential, doesn't it, for DVT? But do we give Clexane or not? So what do? Well, we've got guidelines, and this for your exam is what you would say. I would refer to my guidelines in my hospital or my region. Next slide, I'll give you some examples. Here is an example that we have. DVT, yes, no. Head injury, yes, no, and away you go. And you basically follow some guidelines. Okay? All of your hospitals will, ladies and gentlemen, that you go to work will have these. If not in your hospital, in your remote area, whoever you refer to. In your exam answer, if you're doing an AMC, I would refer to my local guidelines. You're not expected to know these, you're residents. You're expected to know they exist, okay? So you don't have to rote learn these, they're available. They're available online in all of your hospitals, but it gives you a guide. Okay, next slide. And here is the pelvic fracture one. You don't need to know this, it's just there. Next slide. CT heads, will we or not? So when we do the head injury, traumatic brain injury, intracranial hemorrhage, yes. Okay, we're not going to be doing anything until we've got a scan that says we're not really bleeding more, are we? Intracranial hemorrhage, no. Okay, we're going to do that and we're going to initiate chemoprophylaxis. So you can see how we can start to work and risk stratify as best we can within this. So if someone's got an intracerebral hemorrhage, as opposed to, say, an extradural that's been drained, then we are going to be more reluctant to be putting them on Clexane because we can't drain that. An extradural is easy to drain. Okay. Gee, Hannah, you've left and re-entered the waiting room multiple times tonight. Well done, you. I don't know what that means. Next slide. Okay, I think this says limbs, but I've got a Hannah admit in front of my thing. So is this say limbs? Okay, or can I get rid of the Hannah? Okay, see if I do that. Oh, good, it gets away. Limbs. Okay, next one. Next slide. Right, for your purposes, limbs by and large are not going to kill you unless they are femurs. A closed femur is good for a litre of blood. This isn't a neck of femur, this is a shaft of femur. So bilateral femoral shafts is there your 40% blood loss alone, closed. Rule of thumb, if it's compound, double it. Rule of thumb for any compound fracture is double the volume you'd expect closed. So femurs are the ones we worry about with shock because they're the way you're going to lose the blood. The others are worried about for morbidity, but you're unlikely to lose your life. Next slide. Splintage is terrific for a number of reasons. And for God's sake, it doesn't work because somehow when we put the ends together, oh my God. All the splint does, because largely it is venous. Should we be concerned with fat emboli? Absolutely not. Venae. Fat embolus is something that will occur with manipulation. Fat embolus is something that will occur with fixation. Fat embolus is something that will occur at the scene. Fat embolus is not something that is going to stop you splinting anything. And in fact, you will make it worse if you don't splint it. So the answer is you should think about it, but the syndrome is remarkably uncommon. So there is a difference, Venae and everybody, between fat. If we look at your lungs after you have a car accident tonight and break your femur, 100% of you are going to have fat in your lungs. Less than 1% of you will actually have the syndrome. The syndrome is in essence DIC triggered by fat through a mechanism we don't know. That is the syndrome. Actual fat granules are 100% of people who have a long bone fracture. So the two are distinctly different. So the syndrome tends to occur with the reaming or with the internal fixation and is a syndrome of a fever, altered conscious level, decreased platelets, and generally respiratory failure. If, however, we were to put an echo probe down when we do the anaesthetic for fun, and these guys are fixing a femur, 100% of people, we are going to see unmitigated amounts of fat going into their lungs, and they don't get the syndrome at all. So we do not know what triggers the syndrome. So Vinay, you asked a terrific question. The answer is we don't worry about it because it's uncommon. It's a syndrome, we don't know the trigger, but we do know that if we have an unsplinted or unfixed fracture, the risk is higher. Does that help? Do I get a little, oh, good, excellent. Now, splintage works because most bleeding is venous. Therefore, it is low pressure bleeding. Anytime you break a long bone, the effect is to turn a cylinder, the volume of which is pi r squared by the length of the cylinder, into a sphere. And a sphere has the highest volume per surface area of any shape we know, 4/3 pi r cubed. Consequently, if we splint, we decrease the potential low pressure space into which we can bleed. We stop the bleeding by, in effect, pulling the fracture out to length. We don't need to oppose the ends. That's terrific if we get there. That's not the big deal. The big deal is decreasing the potential space. And that's how splintage works. So you can think of it as part of C. What other thing can you do in the acute situation to decrease bleeding that quickly? And the answer is nothing. So splintage becomes part of C for that reason. Added to which, once we have splinted it, we decrease our pain because we don't have ends moving and periosteum being torn. And we can maintain or restore vascular integrity, obviously. But the big thing, particularly for femurs, is it turns a volume space into a lesser potential space. All right, next slide. Now, compartment syndrome is something you will see, and I'm putting it here because particularly those of you who are going to work in remote areas. Let's deal first with compartment syndrome. You are going to be seeing this in a ward setting. The commonest cause is called plaster of Paris splint, because you put on a constricting, non-distensible device in theatre, and they come back and the limb swells. So you need to be aware as ward residents of what a compartment syndrome is. So what are the P's we never want to see? Daniela, you can hit me with one. What are the P's?
Pulselessness?
By that stage, it's time for amputation. So well done, you've gone for the worst, so good girl, but let's hope we find it before that. But
Sorry.
yes, not sorry.
So Hannah got kicked out of the class and she can't get back in, Prof.
Well, how did we kick her out? Was she naughty? Okay. Carolyn, I want another P, please.
Pala.
Pella, okay. Mucky, I want another P.
Sorry, what was the first P? It was
We got for pulselessness. Daniela went for the big kahuna right at the start. Good girl.
pulseless.
Carolyn went for pallor.
Piculos. That one?
Nope. No. Anyone else?
Pain.
Vinay, come on. Pain. Pain what? I want two forms of pain. So the characteristic is they get pain with passive movement as well, because the cutaneous fibers for sensation are on the outside of the nerve. They become ischemic first. They get pain out of proportion to what you find, pain with active and passive movement, then paresthesia, then pallor, and finally pulselessness. So we want to be finding them when their pain is out of proportion to what you can find. And then they will get pain with passive movement. And that's the giveaway, right? Compartment syndrome is something you will see in the ward, because you will see plaster of Paris casts. So you need to be aware of that. Next slide. Crush syndrome is the end result of missing all of this, or having a limb which has been compressed for a long time, and we now release that. What do you think will happen, Daniela, since you were the one who decided we would go for a crush syndrome for our compartment syndrome? What will happen when we release the constricting thing to your patient, do you think?
The rib perfusion injury?
Terrific. Well done. Well done indeed. So we're going to get a shed load of potassium that will go back to a heart. We'll get a shed load of lactate. We'll get a shed load of cytokines. We will get all sorts of and anticoagulants there. We will get a bit of fat and a bit of muscle that will go back as well. And all hell is going to break loose for our patient, because they will get DIC. And that is in effect what a proper crush syndrome is. You have just unleashed a cytokine cascade from hell, because you have just released a whole lot of dead tissue and inflammatory cytokines. So it's really important. You will see the same thing if you are late to a compartment syndrome. You'll see the same thing if you are late and we do escharotomies on burns. We see the same thing with fasciotomies when we have to for limbs after this has been missed for a while. Anything that causes dead tissue that's released quickly, we see. Those of you who will become residents and do their first vascular term, go to the theatre, will see the vascular surgeon telling the anaesthetist before they will release the clamp to the limbs when they do the abdominal aortic aneurysm repairs. Because you've had a clamp on both ends of an aorta when you've put in your graft, when you let that clamp off, what's going to happen is all that blood's going to come back down the leg and come back to the heart, isn't it? The anaesthetist will want to know. Yeah, it is, Mako. It's a progression to the systemic effect of the dead material coming back to a heart. Absolutely. That's what it is. So the pulselessness you see, everyone worries you may lose the limb. You may. However, if you release it, you may lose the patient as well. Now, this has got connotations as we deal with crush injuries, because as we resuscitate them and burns, as we then reperfuse this tissues which are marginal with our resuscitation, can you see how we will turn marginal limbs into compartment syndromes, into then when they get their fasciotomy and or escharotomy, into potential crush syndrome. So we get this vicious cycle. We need to resuscitate to keep them alive. The resuscitation can make the limb worse. The limb's worse, we have to cut. We cut, we release, and we're back to where we were. Next slide. So these are some of the things that we release when we release dead tissue. You don't need to know it's there. I just thought this is the sort of thing that you're going to see with our patients. Look at all the stuff we release. Terrific, hey? And we're going to add the effects of our potassium and calcium, because the calcium will disappear to nothing. Your phosphate will go up with dead tissue, so you don't clot, and you get no inotropy as well. You don't need to know all of that. That's just what happens when we release a tourniquet anytime after a couple of hours. Think now what will happen. Your patient's in a ward with a plaster cast with a compartment syndrome. It's not quite as simple as just the compartment. Unless we deal with this early, this is what we potentially have, a nightmare. Next slide. Put another way, there we are. Prolonged pressure, ischemic insult, ischemia, reperfusion, and you can see back round and round and round that horrible thing goes when we have to start adding fasciotomies into this, because it just fuels itself, doesn't it? This is why on occasion at industrial accidents, you actually chop the limb off at the seam. You don't release it, you just chop the limb off. Tourniquet, chop the limb off and move. Because reperfusing it, you don't have the wherewithal for the patient to survive. And a lot of mining companies, their massive protocol starts with amputation if it's more than a couple of hours. And that's the reason, is you end up with this vicious cycle. Next slide. Crush injury highlights. Hypotension, because you're going to massively third space. Crush injury, we release it, you're going to leak like a sieve because you've now got a systemic response. This is basically burns by another mechanism. So everyone thinks of burns as trauma. As an intensivist, I don't. All burns is pancreatitis that I can see. If you think about burns, that's what it is. It's the cytokine release that causes the problems. You just happen to be able to see where it is. Crush injury is the same. Next slide. Imbalance of potassium and calcium we've talked about, and then we're going to add the various cytokines as well. These hearts are awful. When we looked after the Bali bombing, we had a young 20-year-old get an ejection fraction of 15% for about a week. And that was simply through evacuating him out of Bali and the amount of cytokine release he had, and he had to go to theatre daily on that ejection fraction. There was no other option, and we were just taking a dead tissue daily. Next slide. Renal failure is guaranteed with these people. Rhabdo gives them myoglobin and the rest. Theoretically, you can get rid of myoglobin urea, but you need to give them a lot of fluid. And as you see, giving them a lot of fluid makes everything else worse. So although it sounds nice in theory, in practice it's far more difficult because their lungs get worse with fluid, their heart doesn't like it, and on it goes. Next slide. Secondary complications is as we give fluid, the now marginal tissue in other marginal compartments now swell, and you can see how we can then create more damage with what we had to do to resuscitate them to start with for their first effort. So this thing starts to feed on itself. We had a patient who collapsed in the marathon. He's got a below knee amputation because he got into this situation. 30. Next slide. So without high-level care, crush syndrome generally does very badly. And the badness isn't because you can't look after them from a simplistic point of view of that thing. What you can't do is offer multi-organ support for long enough. So it doesn't mean anything else than you ring early and you get them out early. This is going to get worse. If you think you've got a crush syndrome, get it out early. It's like a burn. And we'll do burns in a little while. Next. Initial management, the pre-hospital setting, always give intravenous fluids before we're going to release the crush part. We have to because we know all hell's going to break loose, don't we? I generally give bicarbonate as well. My recipe is, for anyone who wants to know, it's 150 mils of 8.4% Sodium-Bic, 850 mils of 5% glucose. It's an isotonic solution. I run it as maintenance. That's my recipe, but Sodium-Bic will work and a bit of calcium sometimes as well as they're about to pull them out because I know their calcium will go to nothing. Next slide. ABC approach in hospital. Fluid requirements are large. We go to renal failure. This is what the guidelines suggest you need if you get myoglobinuria. Can you see the problem of 200 mils an hour if you're now going to make every other part of the body swell too and potentially make it worse? So it sounds good. In reality, we dialyse them very early now because it just takes away that problem. So although that's there in the literature, in reality, we just cut to the chase and just dialyse them early and just gets rid of that problem. So it's what, you know, airway breathing dialysis for these patients is a very early thing because to get that much urine output in a heart that already doesn't like it, in a patient that's leaking like a sieve, that I'm worried about more compartment syndromes, isn't real flash. So the easiest way to fix it is I just put the dialysis up and do it that way. Next slide. Here is, for you guys, the P's. Pain and swelling first, and then the late ones. So you notice paralysis is late because the motor fibers are more resilient to the hypoxia than the sensory fibers. Okay, so it's paralysis late. Pain, yes, pain with active and passive movement. It's all P's. Followed by pallor, paresthesia, paralysis, and finally pulselessness. Next slide. Consider the way then this can develop, because your job in the ward is to think about this. So this is all the ways you can get a compartment syndrome in a patient you're going to see in a ward. Just look at all of that. Fractures, yep. Our dressings, yes. So it's not good enough to have just think a plaster. Remember, the Velcro we put around under a plaster, once it's got plaster on it, becomes a circumferential, non-expanding bandage, doesn't it? Snake bites, yes. Intramuscular hematomas, yes. Calf injuries are classic. And then the iatrogenic ones. Note, intravenous, and those of you who have dwelled on intraosseous infusions in children, it's notorious for producing calf compartment syndromes if it didn't go in the bone, but rather went into the soft tissue and you infused fluid. So they're not without their risk what we do. Next slide. Occlusive dressing, commonest one you're going to see, I keep harping on it. Yes, for God's sake, cut it, and you cut it all the way down to skin so you can see skin the whole way along that occlusive dressing, which means when we split a plaster, ladies and gentlemen, it's not the plaster. You want to see skin the whole way along. That's splitting a plaster. Just putting a little split in the plaster itself is not good enough. All the way to skin, okay? All the way to skin is vital, okay? And then after that, we have to think of fasciotomies. The commonest thing is you doing the simple thing, splitting the occlusive dressing. Next slide. Next slide. There we are. The tourniquet I've put in here because it's come in mainstream. It can be used for up to 2 hours. It's put a hand's breadth above a vascular bleeding injury. In the real world of non-military, we see it in industrial accidents. Yes, Makey, I'm seeing your eyes get very big there. Is that a bit, oh my God? We do see it now increasingly with penetrating trauma because we're living in a more penetrating trauma world. The other areas you will see it is going to be anywhere that has a lot of slaughterhouses, etc., where knives are used, and knives into limbs, particularly lower limbs, because they cut towards themselves if you watch your butchers. So we have about 20 in Australia die each year as butchers because they're taught to cut towards themselves. God knows why. So they can work well for that if direct pressure fails. So direct pressure first, then the tourniquet, then you put the time on the tourniquet. You've got about 2 hours. Next slide. This is what's going to happen though. You are eventually going to make a compartment syndrome and potentially, aren't you then, after that, a crush injury, because you are in effect making an avascular limb. So you've got 2 hours and then you get problems. Next slide, we'll get to the end of tourniquet and call it quits, guys. Here is where they can go on. Basically, you can see this is just onto an arm and I've got it there as a picture. It's above. They go on almost as you would a blood pressure cuff, and then they have a windlass effect and you basically twist that until they are pulseless. And then you put a time on that. I usually put a time on the skin in indelible pen above the tourniquet. That way there's no doubt when it went on. Next slide. We might stop with pelvis because it's 9 o'clock and that's probably enough for you guys.
Yeah.
All right, so what we're going to do next time is continue through our little patient, and then we're going to begin to look at a trauma system. And then lastly, after that, we're going to take a real patient who doesn't mind me using his face. And when you see what he's got, you can see how generous he actually was. And we'll take him on his journey of what we did and why and how we did it. All right? And then at the end of all of that, I am going to write a little patient problem for you guys who will be able to answer it for me in written form and be able to send it back to me to mark for you. Isn't that generous of me? But you'll have a few weeks to do that. You'll be able to send it back to my email. All right, so what you're going to be able to do, it's not going to be hard. All I want is I'm going to give you a nice vignette and I want you to have a think about how you would deal with this as a junior doctor in a team, what the principles would be. You don't have to be exact, but we'll give this to you so you can have a bit of a think about at the end of it how we'd apply all of the things we're going to do. All right? It's not going to be technical. I'm not going to ask you to be technical, just gentle dot points about what you do and why. Okay? So 2 weeks' time, we'll start with pelvis. Is that right?
Yeah, start on pelvis, yeah.
All right, start on pelvis, guys. All righty. Okie dokie. Thanks to everyone. Now, if the slides are all up there, is that right, Athel? They're all up for you to look at.
Yeah, they should be.
So you guys can go through them at your leisure. If you've got any questions, send them to Athol. He can send them to me. I can email you back. That's not a problem. But we can talk about them next time and have a bit of a Q&A if you want next time as well, if you've got any thoughts, hey?
Okay.
All right?
Thank you.
All right. Bye-bye.
Okay.
I'm going to dinner now. All right. See ya.